Good afternoon, everyone. Thank you so much for joining this afternoon's webinar, Shifting and Advancing Black Maternal Health Policy. We're going to start in about 2 minutes. We just want to give everyone the opportunity to log into today's webinar. Thank you. And while we're waiting for people to log in using their webinar registration, please feel free to go ahead and type into the chat box and shout out who you are, what organization you're with, and or what state or country you're checking in from on this webinar today. All right, this is exciting. We see that the chat box is on and popping right now on this wonderful Tuesday afternoon. We are going to get started in about 30 seconds. We just want to make sure that one, you can see the screen, and that two, you can hear me clearly. So if people can also indicate that in the chat box just by saying, yes, you can hear me, and yes, you can see the screen. All right, I see lots of yeses. Awesome, thank you. Thank you all for shouting yourselves out. For those that may have just joined right now, everyone is inputting who they are, the organization or agency that they're with, their location, and or country location of where they're checking in and watching this webinar. And we are going to get started in about few seconds. Okay, great. Good afternoon, everyone, and thank you for joining us for today's webinar titled Shifting and Advancing Black Maternal Health Policy, as presented by members of the Black Mamas Matter Alliance and some special guests today for our third annual Black Maternal Health Week campaign. My name is Angela Doinsala Aina, and I am the current interim executive director here at the Black Mamas Matter Alliance. And this is just a brief outline of today's webinar presentation. Before we get started, I would like to cover some logistical items. Everyone is currently muted and will stay muted during the webinar. We will have time at the end for questions through the chat box. So feel free to submit any questions that arise throughout this webinar, and we will try our best to address them after the presentation. Please note that all webinars presented this week will be recorded and available for your viewing on our website. I want to take a moment to express our deep gratitude to all of this year's Black Maternal Health Week sponsors. We'd like to give a special recognition to our change maker level sponsors, and that is the United Way of Greater Atlanta and Merck for Mothers, and our movement builder level sponsors, City Match, Every Mother Counts, Vintner's Daughters, and the American College of Obstetricians and Gynecologists. Your investment in this campaign continues to help us make a significant impact. So about who we are, the Black Mamas Matter Alliance is a national network of Black women-led organizations and multidisciplinary professionals that work across the full spectrum of maternal and reproductive health. We operate at the national, state, and local levels and collaborate to advance policy, promote holistic maternity care, cultivate research, and uplift culture to advance Black maternal health. We do all of this work rooted in birth justice, reproductive justice, the tenets of respectful maternity care, and from the human rights framework. Of particular note, we use the phrase Black mamas to include a range of folks, from women and birthing people across the African diaspora to those who care for and mother our families and our communities, whether they have themselves given birth or not. Founded by the Black Mamas Matter Alliance, the National Black Maternal Health Week campaign intentionally takes place in April, which is recognized in the United States as National Minority Health Month. Additionally, we begin Black Maternal Health Week on April 11th annually to join dozens of global organizations in marking this day as International Day for Maternal Health and Rights, an opportunity to advocate for the elimination of maternal mortality globally. For BMMA, we recognize maternal mortality as a global crisis affecting Black women across the world, not just in the United States. And we join other Black and African women leaders across the diaspora in the fight to end maternal mortality. The purpose of Black Maternal Health Week is to deepen the national conversation about Black maternal health so that public stakeholders understand how root causes like structural racism and gender oppression act as drivers of maternal health disparities. This year's theme is Centering Black Mamas, the Right to Live and Thrive. Centering Black mamas and their right to live and thrive highlights the need for healthcare practitioners, policymakers, and everyone to listen to Black mamas in their care and service provision. This is especially important now that we have better data that provides further evidence that the lack of quality of care and disregard for Black women's humanity is deadly. By centering community-driven solutions, we can help Black women, their family, and their children thrive. We're honored to have such a dynamic set of experts for today's webinar. First up, we have Mr. Jack DiMatteo. Jack DiMatteo is a healthcare policy fellow in the office of Congresswoman Lauren Underwood, where he is staffing the Black Maternal Health Caucus. Congresswoman Underwood co-founded and co-chairs the caucus, which works to address America's high and rising rates of maternal mortality and severe morbidity, and the racial disparities in maternal health outcomes in the United States. Jack completed his Master of Public Policy in May 2019 at the University of Virginia Frank Batten School of Leadership and Public Policy. He is a 2019-2020 David A. Winston Health Policy Fellow and is originally from Deerfield, Illinois. We welcome Jack to this webinar. Jack, are you ready?
Yes, thank you so much, Angela. Can you hear me?
Yes, we can.
Okay, great. Yeah, you can go to the next slide, and thank you so much for the introduction and to everyone for being here today. Congresswoman Underwood, of course, wanted to do the full presentation herself, and we're hoping that she will be able to join shortly. But in the interim, it's an honor to speak with you. First, would like to thank Angela for your leadership of Black Mamas Matter Alliance, for putting on Black Maternal Health Week and this programming, and of course for your year-round commitment to this issue. Mallory, thank you for your assistance with coordinating all the logistical details, and again to everyone who's joining this webinar today. As Angela mentioned, Congresswoman Underwood is a co-founder and co-chair of the Black Maternal Health Caucus, which was founded about 1 year ago by Congresswoman Underwood and Congresswoman Alma Adams to elevate the Black maternal health crisis within Congress and to advance policy solutions to save lives and end disparities. In the past year, the caucus has really been busy. We've done a lot, added more than 100 bipartisan members, hosted events, advanced legislation introduced by other members like the Helping Moms Act from Congresswoman Robin Kelly and others. And on March 10th, the caucus, led by Congresswoman Underwood, Congresswoman Adams, and Senator Kamala Harris on the Senate side, introduced the Black Maternal Health Momnibus Act of 2020. Today, I'd like to spend a little bit of time going into the policies within the Momnibus. But first, we wanted to discuss the policy development process for the Momnibus because while the policies themselves are important, the process of how we got there is even more important. And specifically, something that Angela referenced is the urgent need of centering the voices of Black women and their families who have been affected by this crisis. When the Black Maternal Health Caucus hosted its stakeholder summit in July, one of the really moving points that stuck with us was from Elizabeth Dawes-Gay, a co-founder of Black Mamas Matter Alliance. And she said, listen to Black women, trust Black women, invest in Black women. The answers to this crisis lie within the Black community. And that has really been a North Star for the caucus and the work that we're doing. We know that the crisis that we confront is enormous. It's critically important that we act, but it's also not hopeless. There are solutions out there, and we know that those solutions are in Black communities. We know that when moms have care and support from providers they trust, when social determinants of health are addressed, when we take care of the issues that we hear about from Black women and their families, we see better outcomes. And we really view the role of the caucus as lifting up those solutions and expanding them through critical investments in solutions that have been developed by people like the leaders of Black Mamas Matter Alliance. So we worked closely with Black Mamas Matter Alliance, with so many incredible Black women-led stakeholder groups and organizations across the country to develop the legislation. And Angela, if you wouldn't mind going to the next slide, I'm happy to now speak a little bit more about the individual bills within the Momnibus. So Congresswoman Underwood introduced the Black Maternal Health Momnibus Act of 2020, that's HR 6142. And the Momnibus included 9 different titles, which were also introduced as standalone legislation. Each of those are laid out here. So I'll give some sort of a high-level overview of those right now, and happy in the question and answer session later to go through any or all of them in greater detail. The first bill in the Momnibus was the Social Determinants for Moms Act, which was introduced by Congresswoman Lucy McBath of Georgia. And this bill recognizes that when we're talking about maternal health outcomes, we have to talk a lot more broadly than just the healthcare system. We know there are a number of non-medical factors like access to housing, transportation, nutrition, quality environmental conditions that have significant influences on maternal health outcomes. And so the Social Determinants for Moms Act makes financial investments and research investments in those social determinants individually and then holistically. So for example, it calls for the Department of Housing and Urban Development to put together a Housing for Moms task force, many ways advancing some of the key issues the Black Mamas Matter Alliance has laid out in its policy agenda to make sure that moms have access to safe, adequate, affordable, quality housing for the duration of the prenatal period and the postpartum period, and of course beyond. We also know that even if a mom has a good healthcare provider, it doesn't matter if she can't get to or from those appointments because she lacks access to transportation. So those are examples of some of the issues that we confronted in that bill, and look forward to advancing that as well as the other legislation in here. The Kira-Johnson Act was introduced by Congresswoman Adams, the co-founder of the caucus, and certainly would be remiss if we didn't take a moment to think about Kira, both how she lived and how she died, a Black woman who in so many ways embodies the pain, the really human stories behind all these glaring statistics. And of course, it's a special way to honor the legacy of Kira by the advocacy that her husband Charles continues to do. And it was an honor to have Charles join us when we introduced the Momnibus on March 10th. The Kira-Johnson Act really builds on that notion that Elizabeth Dawes Gay described, that the answers to this crisis lie within the Black community. It makes investments in community-based organizations, specifically working to improve maternal health outcomes for Black women. This includes investing in doulas, it includes addressing social determinants of health, and really recognizing that we have community-based solutions that are making a difference, and we can use the financial power of Congress and the platform of Congress to advance that work nationally. The bill also advances training. We know that Congresswoman Adams and Senator Harris have introduced the Maternal Care Act in the past to make investments in implicit bias training. And this bill goes beyond, recognizing that sometimes it's explicit bias, sometimes it's racism, and we need to take that on squarely as well. We also need to think beyond just the provider and think about everyone who a mom and her family might interact with in a birth setting, from security officers to front desk people, and make sure everyone's getting these trainings. And then finally, we know that we need some steps towards accountability mechanisms on the other end when those trainings aren't enough. And that's why the Kira-Johnson Act includes funding for the establishment of respectful maternity care compliance offices to institutionalize mechanisms for reporting cases of bias and disrespect on the basis of race, ethnicity, or another protected class, and also follow-up mechanisms, not just from the hospital to the patient, but also from the hospital to the Department of Health and Human Services. So we can start to develop some of those accountability mechanisms and really get towards a system in which every mom is heard and valued when she goes to give birth. The Protecting Moms Who Served Act was a bipartisan bill introduced by Congresswoman Underwood and Congressman Gus Bilirakis. First, it calls for the first ever comprehensive study of the scope of the maternal health crisis among women veterans. We know that women who have worn the uniform face some unique circumstances, ranging from post-traumatic stress disorder to military sexual trauma, that might have direct implications for her birth outcomes. And we need to study that robustly to take appropriate action. The bill also provides funding to the VA to continue to build out its maternity care programs for women veterans who get their health care through the VA. The Perinatal Workforce Act was introduced by Congresswoman Gwen Moore, and it recognizes the need to both grow and diversify the perinatal workforce and ensure that every mom, no matter where she lives, has access to culturally congruent care and support for the duration of the prenatal period, labor and delivery, and the postpartum period. So this bill really complements an existing piece of legislation called the Midwives for Moms Act, and recognizes that in addition to funding for midwifery, we also need funding for nurses, PAs, and then a wide range of community supports, ranging from doulas to community health workers to navigators and peer supporters, who can really be an incredible source of support to women, again, for that entire prenatal and year-long postpartum period. The Data to Save Moms Act was introduced by Congresswoman Sharice Davids, who's one of 2 Native American members of Congress, and the bill includes the first ever study of the full scope of the maternal health crisis among American Indian Alaska Native women, which is the only group that's suffering rates of adverse maternal health outcomes that are comparable to Black women. The bill also makes investments in diversifying our Maternal Mortality Review Committees, a topic that will come up later, and that's diversity racially, ethnically, and also professionally. And the bill establishes a task force to make sure that we are implementing and standardizing data collection and reporting and quality measure practices that adhere to evidence and are standardized across the country. The Moms Matter Act was introduced by Congressman Joe Kennedy. It recognizes the critical role of mental health and substance use disorder in influencing maternal health outcomes. Of course, we hear about postpartum depression, and that's part of it, but we know this is also in the prenatal period, and it even goes beyond depression. It includes anxiety, substance use disorder, and other behavioral health issues. The bill focuses on investments in collaborative care models, types of culturally congruent care provided in freestanding birth centers, group prenatal care models, and importantly, this is another bipartisan bill introduced not only by Congressman Kennedy, but also another one of our Republican members of the Black Maternal Health Caucus, Congressman Billy Long, as well as Republican Congressman John Katko. The Justice for Incarcerated Moms Act was introduced by Congresswoman Ayanna Pressley. And when we think about the most vulnerable among us at the most vulnerable times of their lives, we can think of pregnant, birthing individuals who are incarcerated, and this bill invests in them. First off, it builds on the First Step Act that worked to end the practice of shackling in federal prisons, but we know that pregnant women continue to be shackled in state and local detention centers across the country. This bill includes financial incentives to end that practice once and for all. The bill also implements another comprehensive study to really understand the full scope of the maternal health crisis and the unique challenges faced by incarcerated birthing individuals. And finally, the bill includes funding to invest in programs that ensure that pregnant and postpartum individuals who are in jails and prisons have the care and the support that they need at this really vulnerable time. The Tech to Save Moms Act recognizes that although digital tools alone are not going to solve this crisis, they can address specific dimensions of the crisis, particularly in underserved areas for both patients and providers. And so the bill makes investments in those spaces. The bill also includes a study to ensure that as we continue to move in the direction of artificial intelligence and other technology around maternity care, that we're not building bias into some of those models in a way that could actually harm the very people we're trying to help. Finally, the Impact to Save Moms Act, which was introduced by Congresswoman Jan Schakowsky, implements a maternity care payment demonstration project, recognizing that the way we pay for maternity care is going to have a significant influence on the outcomes that moms have. And the bill also includes a study on some very specific interventions of how we can ensure continuity of health insurance coverage from the duration of the pregnancy, the full year-long postpartum period, and even beyond. So I know that was a quick overview, and I'm happy to speak to any of those bills individually later on. But Angela, if you wouldn't mind going to the last slide, I'll wrap up here before our next speaker by just mentioning that, some people have asked what the next steps are for the Momnibus, particularly in this moment where so much of the focus is on the pandemic. And one of the things that we talk about is that throughout COVID-19, babies are still being born. And in fact, there might be some disparities that are not only continued, but actually exacerbated by this pandemic. And it's why we need to have a really specific focus on addressing the Black maternal health crisis at all times, and specifically at this time. So we could really use your continued support. We're so grateful for the many partners who I'm sure are on this webinar, like the Black Mamas Matter Alliance and so many others whose partnership made the legislation possible and whose advocacy will be necessary to move this bill. And I look forward to working with all of you on this, and look forward to the Congresswoman being able to thank you all as well. I guess I'll hand it over to Angela for the next speaker at this time. Thank you so much.
Thank you so very much, Jack. We really do appreciate that, and appreciate that thorough breakdown of the Momnibus bills. Our next speaker is Dr. Jamila Parrott. Dr. Jamila Parrott is a fellowship-trained, board-certified obstetrician and gynecologist with a comprehensive background in family planning and reproductive health. Dr. Parrott provides on-the-ground, community-based care focusing primarily on the intersection of sexual health, reproductive rights, and social justice. In addition to her work as a clinical provider in Washington, D.C., Maryland, and Virginia, she serves as a reproductive health care consultant, where she develops, organizes, and facilitates health education workshops and outreach events focused on topics such as health equity, reproductive justice, adolescent health, contraception, and family planning. We're also proud to have her as a member of the Black Mamas Matter Alliance. I'll now turn it over to Dr. Parrott.
Thank you so much, Angela, for that introduction, and thank you all for joining us today. I'm really grateful to have an opportunity to talk about the work we've been doing here at the Black Mamas Matter Alliance and the issue brief I've had the privilege of working on with BMMA. As was mentioned in the introduction, my name is Dr. Parrott. I'm an OBGYN and a reproductive healthcare specialist and activist based in DC. And I just appreciate so much the work that the Black Maternal Health Caucus and Jack and BMMA have been doing to really advance equity in maternal health. Jack and Angela both spoke a little bit in their introduction about the shameful inequities in maternal health in the U.S. And in a country that spends more per capita in healthcare services than any country in the world, the fact that Black women die at 3 to 4 times the rate of white women during pregnancy, delivery, and postpartum is truly unconscionable. As a Black woman, a mother, and a physician myself, I've seen firsthand how these inequities impact our communities, now even more pronounced as the COVID pandemic continues to disrupt care provision. In recent weeks, we've truly seen inequities in our health systems and structures of care laid bare, magnified, and exacerbated 1,000-fold by this pandemic. And unfortunately, the long-term impact on the health and well-being of pregnant and parenting people, as well as in our communities, has yet to be seen. Well, with that said, we must use this time to continue to address, confront, and combat these inequities and access care and outcomes in ways that are comprehensive, holistic, and center those most impacted. And that's why it's such an honor for me to partner with organizations like the Black Mamas Matter Alliance, who've really been leading this work in so many ways, including the framing of conversations about the need for MMRCs, or Maternal Mortality Review Committees. Next slide, please. Maternal Mortality Review Committees have been suggested as one strategy to address these inequities in maternal health outcomes. And the premise here is that in order to reduce maternal deaths, we need to know what caused or contributed to these deaths. And this can be accomplished by MMRCs, whose charge is to review each maternal death and ideally put in place recommendations for actions to prevent them from occurring in the future. By reviewing maternal deaths in their jurisdictions, MMRCs are able to assess contributing factors, determine preventability, and examine root causes that lead to maternal death. States often rely on lawmakers to pass authorizing legislation to establish an MMRC, to outline committee composition, and to define reporting expectations and timelines. Currently, every state in the U.S. has or is planning to implement a Maternal Mortality Review Committee, but there's a tremendous amount of variability in their structure, composition, and in the quality of these committees. And they vary across states as to whether they are permanently established by statute or a temporary measure, their authority to access records, and whether they use common data systems or varying ones differs as well. And we see a huge amount of variability in how often they meet, publish reports, and whether they develop actionable recommendations to prevent future deaths. Many rely on volunteers instead of designated members, which impacts level and diversity of participation. These challenges in standardization of process and measurement can have profound impacts on the success and sustainability of MMRCs. The Black Mamas Matter Alliance believes that improving maternal mortality and morbidity data is essential in addressing the maternal health crisis in the United States, a crisis that disproportionately impacts Black women. Furthermore, BMMA asserts that in order to optimize data quality, communities most impacted must be meaningfully engaged throughout the data collection, analysis, and policy recommendation phases.
Dr. Parrott,
yes.
I'm very sorry to have to interrupt you at this very moment. We have our special guest that's on the line, and so that we're able to because she has a short amount of time.
Absolutely.
Yes, we're going to pause you right quick, and we're going to come right back to you.
No problem.
I'm going to kind of go back. So today we are very excited and honored to be joined by a very special guest to help frame and provide some perspective for the discussion we will have around policy in Black maternal health. Congresswoman Lauren Underwood serves Illinois' 14th Congressional District and was sworn into the 116th U.S. Congress on January 3rd, 2019. Congresswoman Underwood is the first woman, the first person of color, and the first millennial to represent, go millennials, to represent her community in Congress. She is also the youngest African-American woman to serve in the United States House of Representatives. Congresswoman Underwood, along with Congresswoman Alma Adams, and we are so grateful for Congresswoman Alma Adams as well, is the co-founder and co-chair of the Black Maternal Health Caucus in Congress. Welcome, Congresswoman Underwood.
Hi, everybody. Thank you so much for having me. Thank you for the introduction, Angela. And I'm so sorry to our presenter who was such in the zone. But I just wanted to call and recognize the importance of Black Maternal Health Week. I want to thank the Black Mamas Matter Alliance for hosting this gathering this afternoon. And, you know, have been reflecting on the idea of having this week of reflection and recognition on Black maternal health during the middle of a pandemic. In recent weeks, data has been showing the stark disparities in COVID-19 outcomes that are reflective of health disparities broadly. In my state of Illinois, for example, we know that Black women are about 6 times more likely to die from pregnancy-related causes than white women. And now we're seeing that Black residents in our state, who represent about 15% of our state's population, account for more than 40% of our state's COVID-19 fatalities. The pandemic is revealing and likely exacerbating alarming inequalities that we need to address right now, which makes the work that you do and the work that we do with the Black Maternal Health Caucus even more urgent. Just over a year ago today, Congresswoman Adams and I launched the Black Maternal Health Caucus. We were proud to have the Black Mamas Matter Alliance with us that day and all the work that we've done since then. In just a year, the caucus has been so busy. We have more than 100 bipartisan members. We've hosted events like the Stakeholder Summit, briefings on the Hill, and of course, the celebration of the Momnibus introduction just last month. We've been supporting Representative Robin Kelly's leadership on the Helping Moms Act, a bill that passed unanimously out of the Energy and Commerce Committee in November. And then, of course, we introduced the Black Maternal Health Momnibus Act of 2020. I think you've heard a little bit about the Momnibus, 9 bills to build on existing maternal health legislation to comprehensively address this crisis. The Momnibus legislation makes important investments in social determinants of health, in community-based organizations, the growth and diversification of the perinatal workforce, improvements in data collection and quality measures, which you were just talking about, digital tools like telehealth and innovative payment models. Now, in addition to direct efforts to improve Black maternal health outcomes, the Momnibus focuses on high-risk populations, including women veterans, incarcerated women, and Native Americans. And, you know, just as important as the policy was really the process and working with organizations like the Black Mamas Matter Alliance and centering the voices of Black women has made our legislation stronger. I want to thank you for all the work that you've been doing, let you know that we are here to support you in this work and are really counting on the feedback from all of you as we continue to move forward to fight to save the lives of moms and babies around this country. And it's really been an honor to do this work with each of you. It's my favorite thing to work on since I've been in Congress, and, you know, being able to do this kind of impactful work has just been the highlight of my time in Congress. Thank you for all that you do, and I'll turn it back over to Angela. See you in person soon, everybody. Take good care of yourselves.
Same to you, Congresswoman Underwood. Thank you so, so very much. We are appreciative of all the work you are doing along with the Black Maternal Health Caucus and also along with Congresswoman Alma Adams and your staffers and everyone that we've been working with on the Hill. BMMA is very much a proud supporter and partner of the Black Maternal Health Caucus. Now I will transition it back to Dr. Jamila Parrott. And thank you so much, Dr. Jamila Parrott, for your patience. We really do appreciate it.
Thank you, Angela, and thank you, Representative Underwood. It's really been a pleasure to work with the Black Maternal Health Caucus, and thank you so much for your leadership in supporting equity for Black women. Where we left off was one slide back, actually talking just a little bit about the challenges in the standardization of process and measurement and the impact that this can have on the success and the sustainability of MMRCs. And so we know that this quality data is really what's going to lead the way in right-ending this crisis. And we assert at BMMA that in order to optimize data quality, those communities who are most impacted have to be engaged throughout the process. MMRCs are one piece of a multi-pronged approach that's necessary to do this work. Next slide, please. As you heard earlier, we have had tremendous champions in the legislative effort to move these issues forward. And in December 2018, grants were established through the Department of Health and Human Services to support MMRCs via HR 1318, the Preventing Maternal Deaths Act. And this bill was intended to establish support existing MMRCs in states and tribal nations across the country through federal funding and reporting of standardized data. In March 2019, we saw the CDC, housed within the Department of Health and Human Services, announce funding for the formation and management of MMRCs with the hope of addressing some of the aforementioned challenges to committee formation and data collection. And we hope that these grants will lessen these challenges and encourage the formation and sustained progress of MMRCs. At this point, 38 states have active MMRCs that are recognized by the CDC, and several more have passed laws but have not yet begun reviewing cases. We've seen a steady increase from the number that existed in 2010, and a lot of that is as a result of this legislative effort. Next slide, please. So as states began to enthusiastically form MMRCs in response to the increased public and media conversation about maternal death inequities, and with newfound funding through federal agencies, the problem of translating the theory of maternal mortality review committees into practice really becomes clear. Inconsistencies in determining what to count and how to track these maternal deaths produce challenges, given that data is often inconsistent and incomplete at national and state levels. Lack of funding at a local level persists and impacts authentic participation. And familiar tropes that blame pregnant people for poor outcomes continue to dominate the narrative explanations for death and severe maternal morbidity. Poor pre-pregnancy health, increased incidences of blood pressure, of elevated blood pressure or obesity are often pointed to and identified as primary contributing factors, while social determinants of health and structural and governmental divestment in community is ignored or overlooked. In response to the flurry of MMRC formation, the Black Moms Matter Alliance has identified strategies for MMRCs to more effectively address inequities in maternal health as they seek to review morbidity and mortality data. Next slide. Access to consistent, high quality, and reliable data year after year is critical in establishing benchmarks, setting goals, and measuring progress towards improving outcomes. Allowing MMRCs to identify both the characteristics of people who died during pregnancy complications and the specific circumstances that lead to these deaths is essential to inform critical action steps for developing strategies to prevent maternal mortality and severe maternal morbidity. And to this end, we believe that determining cause of death alone is not enough. MMRCs must collect data concerning pregnancy-related deaths that goes beyond cause of death in order to evaluate quality of care in maternity care services and recommend systemic changes in delivery care models to improve outcomes. We know that improved surveillance systems are necessary to accomplish this, and that this data must be triangulated so that severe maternal morbidity and near misses can be used to provide us with broader understandings of the systemic quality of care impacting Black people during pregnancy and in the postpartum period. And finally, translating maternal health review data and findings into publicly accessible reports is critical to promote agency, autonomy, and accountability. It provides legislators with the ability to create evidence-informed laws and policies for solutions around both systemic issues and those related to individual patient outcomes. Next. Understanding the role of the multiple layers of contributing factors for maternal death and severe maternal morbidity and mortality requires rethinking about the structure of MMRCs. Traditionally, MMRCs have been made up of primarily obstetricians and other physicians. But more recently, some committees have advocated for expanding committee membership to be more multidisciplinary, including representatives from public health, nursing, midwifery, pathology, behavioral health, and community-based organizations, with the understanding that the case review, deliberations about individual deaths, and recommendations that come out of the committee directly align with the committee structure. Diversity of experience, points of view, and profession are an asset to understanding the complex and layered causality of maternal morbidity and mortality. Prioritizing organizations grounded in birth justice, reproductive justice, and human rights frameworks permit members' composition to be reflective of those most impacted by inequity. But simply inviting diverse viewpoints into the room is not enough. Mechanisms for meaningful engagement must be prioritized as well. Given that many MMRCs rely solely on volunteer or governmental appointed members for participation, the ability for community members to participate fully is limited. Providing practical support for participation to attend meetings includes supporting transportation, childcare, and meals as needed. And it's imperative to ensure membership is diverse and participation is authentic, meaningful, and sustainable. Next slide. The translation of deliberations regarding causality of death in individual cases to be meaningful policy and programmatic solutions for prevention is obscured from public view. Promoting transparency in this process is key to build trust and relationships in communities regarding the desire to improve maternal and public health outcomes. The provision of civil society members with information about state government efforts to prevent maternal mortality and morbidity and ensure safe and respectful maternal care aids in the community's understanding of strategies and ensures that they're rooted in equity. And these efforts must be matched with funding of maternal health solutions that engage the participation and knowledge of affected communities and emphasize asset-based, resilient cultural models as opposed to previously prioritized models that approach bad outcomes with a deficit framework. Next slide. Holding systems and structures accountable for both the availability and quality of care delivered in communities is a necessary and underutilized part of maternal mortality review committees. Accountability in health systems can be used to inform policy, but they also must include accountability in decision-making, performance evaluation, inclusivity, and transparency at all levels of the health system. It ensures that the most marginalized individuals can access maternal health information and services, and that they can voice their concerns, claim their rights without fear of reprisal, and seek remedies when their rights are violated. Accountability measures should prioritize the delivery of quality, comprehensive, patient-centered, and trauma-informed care, and should center the individual throughout their development and implementation. Next slide. The Black Mamas Matter Alliance understands that to evaluate the nature and true magnitude of maternal health problems occurring, states need systems, including MMRCs, to collect accurate and complete data on a range of relevant variables. Maternal health surveillance activities should be a core and routine component of the public health work in which state health departments engage. A standardized and inclusive maternal mortality review process can integrate these data collection and case identification activities into its operations. However, in states where the formal review processes have not yet been implemented, state health departments can still work to strengthen data collection strategies in order to identify the scope and nature of pregnancy-related deaths and severe maternal morbidity. MMRCs and state health departments can also share best practices learned during the review process and via subsequent intervention programs with other states to improve review mechanisms and establish innovative interventions. Let's be clear, the maternal mortality epidemic is not new. It was not created by COVID, and it is an issue that advocates and activists have been working to address long before this pandemic took hold of our communities. We know at BMMA that maternal mortality review committees are one critically important mechanism to investigate, acknowledge, and make recommendations to prevent these deaths. We are grateful to legislative and grassroots allies who work to ensure that the promise of these committees aligns with the reality. Thank you so much. Last slide. And we'll turn this back over to Angela. Thank you all so much for your time.
Thank you so very much, Dr. Parrott. We really do appreciate that and for the thorough insight and the call to action. Our next speaker, who's also going to be our last speaker on our webinar, and she's definitely not least. She is very, very loved, and we appreciate her for joining us today. We are going to be hearing from Jessica Roach. Jessica Roach is the co-founder and executive director of the Restoring Our Own Through Transformation, ROOT, a nonprofit organization focused on providing community-based maternal child health and birth support in Columbus, Ohio. As a Black women-led reproductive justice organization, ROOT offers affordable doula services, healthcare provider trainings, and organizational consultation while validating their clients' environmental stressors. We also thank Jessica, who now serves as a member of the board for the Black Mamas Matter Alliance. Jessica, are you ready?
I am.
Awesome.
Thank you so much. So again, thank you so much, Angela, and to our guest speakers and everyone that is doing the work during this time. Definitely appreciative of our kindred partnership with the Black Mamas Matter Alliance. And I'm very honored to be able to be speaking today. Again, my name is Jessica Roach. I am the Chief Executive Officer and partner with Restoring Our Own Through Transformation, also known as ROOT. We are a Black women-led reproductive justice and birthing justice organization dedicated to addressing Black maternal, infant, and family health through direct service, policy, and advocacy. Next slide. Just a little bit about us, a little bit of background before we get to the content of our engagement today. We are a collective of concerned Black families, families of color, community members, advocates, and interdisciplinary professionals dedicated to decreasing maternal and infant mortality in Ohio. Our mission is simple. It's to comprehensively restore our collective well-being through collaboration, resource allocation, research, and re-empowerment. That's important to be very clear because we understand and know that we as Black people come with our own resources and simply need to be able to have those resources lifted and reignited within our own communities in order to meet the needs of our parents and families. Next slide. And just a little bit, we do just a little bit of a distinction. Our perinatal support doulas are full spectrum, and they provide perinatal support as well as spectrum across the reproductive health spectrum. We also do provide breastfeeding education, certified lactation consulting, advocacy, and we are grounded in family-centered informed decision. Next slide. So what we're talking about today a bit, and just narrowing it down, is in regards to doula policy, especially now that we're talking about COVID-19 and some of the variations and how it has impacted the ability for perinatal support workers and doulas to be able to complete some of their interrelationships and jobs with the clients that they serve. From a national perspective, I think that we all are aware that we have seen some of the news stories that have come out of the media. In particular, there was focus on New York Presbyterian that at one point had stated that there was not going to be an allowance for any visitors whatsoever for pregnant women. But there are extreme variations in protocol, and there are constant changes that are happening within the hospital systems. We do have some hospitals and birthing centers, both freestanding and hospital associated, that are still allowing a 2-person support network. Most have moved to what is considered a 1-person support. Multiple states are also proposing what are considered auxiliary maternity units as an option. This also has some variances, however, regarding perinatal support doulas and whether or not they are an integral part of the care team. There's also options for virtual support. Some of those options for virtual support are actually supported by the health systems themselves. Although one of the concerns has been the ability to continue to provide care regardless of what the circumstances may be inside of the labor and delivery room. And so I know that there has been some options of being able to opt for independent resources, including utilizing of Zoom technology, FaceTiming, and Elevate platforms that are coming directly from the either CBOs or the independent doula support persons to the clients themselves. Next slide. Moving into what we're looking at with not only Central Ohio support systems, but Ohio overall, some of the concerns and the issues that we have had and we have seen is that, again, there are extreme variances throughout the hospital systems in regards to the support person and support person's policy. There are similar one support persons that have been adopted throughout Ohio major metro hospital systems. Although I do want to note, in being able to speak with Birthing Beautiful communities this morning and getting an update from Cleveland, we are aware that metro hospital systems are still allowing for a 2 support person system. This is important to note, because there are a few things that we need to make sure that we are addressing when we're talking about support persons in the room. One is making sure that we are obviously being very, very clear about mitigating the transmission of COVID-19, but also being very clear about the role of the perinatal support doula as an integral part of the perinatal care team, and then also having the allowance to be able to have that type of communication and development of a plan of care directly with their client and with the healthcare team, and maintaining safety. We do not have any other information other than anecdotally at this point, but from an anecdotal perspective, we have not heard of there being any concerns with an increased rate of transmission of COVID-19 when there is a 2 support person. Both support persons have to submit to the same screening processes. And it's very clear that the support persons have to utilize particular PPE equipment in order to try to mitigate the transmission of COVID. So that is good news that is coming out of that policy from Metro Health Systems. But then one of the other issues that we have seen in regards to the policy variation and the choice of support person can be some of these stricter definitions. Some of the language in and of itself includes specifically doulas are not permitted for several hospitals. We're going to get to that in just a minute and get more specific about it. One of the big concerns with doulas not being permitted, or that being the language, is that that has a tendency to take into, and especially when we're talking about women in our communities and definitions of families and support persons, sometimes the doula is the only support person. That is not as frequent, but we do see that being an issue. And so what it is that we're addressing now currently as an organization is trying to change some of that language to be specific to, if it is going to be one support person, it can be one support person of choice, because otherwise stating specifically that doulas are not permitted does increase the risk of having some of our clients and pregnant persons overall having to labor on their own in labor and delivery. Next slide. And then drilling it down to Columbus, Ohio, and what is happening here in our own area is very specifically with the Ohio State University Wexner Medical Center. Obviously, they have also moved to a visitors no longer allowed. There is an exception for maternity patients. However, this is one of the things that we were discussing earlier, is that doulas are no longer permitted to accompany maternity patients, which can and has created some issues for those where the doula may be the only support person. One of the things that we are doing within our organization is making sure that not only do we have the connection with the families, but that we are developing what could be potentially a secondary support person that may be allowable without it being a doula as a family member. And then actually, to be very clear and honest, part of the advice that has been given is that we do not identify as doulas coming to the hospital if we are the only support person, which fundamentally, and we're not advising that that is the case, especially when we're talking about the integral role and impact that perinatal support doulas have, in particular when it comes to Black maternal, infant, and family care. Ohio health systems have gone a step further to be very specific about not only is it limited to one support person, but to be clear about some of the definitions of what that support person can be, in particular for minors. If the mother is a minor, she can only have either a parent, she can have a parent as a parent or guardian visitor, in addition to the father of the baby, which again, we have been addressing with the health systems and with the Ohio health systems. And as we get further into the conversation, with some of the support systems that we have through the Ohio Black Maternal Health Caucus, and being able to really address this type of language, because it does become challenging when you're talking about different types of supports within family systems. Next slide. And then in regards to Mount Carmel Health System, which is our other primary health system here in Columbus, Ohio, it is also a no visitors permitted. These exceptions may be made on a case-by-case basis. Those exceptions do lend to maternity care. The visitors must be 18 years of age or older, either immediate family members, power of attorney, guardians, or patient representatives, and they must be healthy with no symptoms of illness. So they do have some specific definitions. What we will state in regards to Mount Carmel Health Systems is that they have recognized that the doula can be the primary support person in those instances, and allowing for that to be the one person that is in the room. Representatives from Mount Carmel Health Systems are actually also actively engaging with Root to develop some co-care primary team. This will potentially include some specialized training. However, that is just currently in conversation. We have not been able to follow through and fill the gap in that. And so in the interim, we are doing what we can as far as an organization is concerned, is making sure that we have developed the key steps to provide the necessary virtual support and family re-empowerment, so that our families are able to go into their scenarios and have the birth experiences that they're looking for. They're also doing some significant work at home with prolonging labor at home and keeping in touch with primary care physicians and providers. And this has actually helped develop some deeper relationships with some of the providers that have already been supportive to us within Columbus, Ohio. Next slide. One of the big issues, and one of the things that we want to point out, not only when we're talking about overall Black maternal health and how it is that the perinatal support doula is of such importance, but it's also making sure that we're talking about it, and especially in relationship to COVID, and where we are seeing, obviously, as Dr. Parrott pointed out, and Congresswoman Underwood, that we are seeing these significant health disparities, and know that we are being disproportionately impacted within the Black community. In particular, when we're talking about COVID, not only infection transmission, but in cases of deaths. The conversation often is centered around the health disparities, and this is very clear when we're talking about it from a Black maternal perspective, Black infant health, and then overall chronic health issues that impact and negatively impact our communities disproportionately. We talk about this from the perspective of the social determinants of health. I know everyone is familiar with those, but just in conversation, we know that obviously there are issues that negatively impact us, including issues surrounding poverty, incarceration, neighborhood demographics, and having access to care. But the reality is, and what we are clearly seeing, and wanted to point out today specifically in some of the information that we're receiving in differences in counties, is that you can see clearly that it's not just about these social determinants of health. In order to actually address the issues surrounding our health from a Black maternal health space, from an overall Black family health space, we have to move to having the conversation about the root causes of what has created these social determinants of health within our community. Next slide. And in order to do that, we have to address the structures and the policies and institutional racism, not race. Let me be clear about that. We have to be specific about addressing the institutional policies that have been developed over a 400-year time span that are still enforced, that have created what are considered these social determinants of health. We know clearly that you cannot talk about us in a silo, and you cannot talk about things like access to or lack of access to affordable, stable housing without having the conversation about the policy that was created in 1932 that created redlining and therefore made it challenging for us to be able to have our own home ownership, and still impacts us today. You cannot have conversations about high rates of incarceration and high rates of excuse me, I'm sorry, high rates of incarceration without having conversations about the issues with police brutality and police interaction in Black communities. You cannot have this conversation without really taking a look at the numbers and the research and seeing where the areas that are most impacted, that have the highest numbers of Black maternal and infant mortality and morbidity, very closely relate to some of these same issues that we're talking about in regards to neighborhoods that have been redlined, in regards to neighborhoods that are having those higher levels of interaction of police brutality, in regards to having issues with disproportionate incarceration, the myth of the absent Black father, the higher and growing rate of Black women and being incarcerated. We have to be really clear that the role that we serve and how we view this from our perspective within our organization, and I know this is similar for other organizations across the country, is that the role of the perinatal support doula is here to make sure that we are able to re-empower our families, that we know that the best way to care for us and to be able to address the health disparities within our communities is to be able to have Black people serving other Black people. To be very frank, we come from an interdisciplinary perspective and levels of experience that have shown and been very clear where the statistics within Ohio are still at an extreme disparate rate. Our organization in and of itself currently has a 0% Black maternal and infant mortality rate. And we do that because we know that we already come with our resources that we need. And one of the biggest concerns when you're talking about this from your own locale and when you're thinking about this from a larger policy perspective is the level of stress that it can cause when you are disrupting relationships, period. But in fact, when you're disrupting trusted relationships that have been developed since maybe even before pregnancy, but definitely from the early point of pregnancy, to say that you cannot have the support person that you want without having consideration for the family and for the perinatal support worker to be able to develop the best plan of care to make sure that we are addressing the mitigation of the transmission of COVID, to make sure that we are being very clear about whether or not a virtual support system would be a better option, or if an in-person support would be a better option. If we are not taking all of those things into consideration, we are going to be negatively impacted. And I'm saying we, as a Black community, we are going to be disproportionately and negatively impacted, more so than those of our white counterparts. Next slide. And that's why we are so grateful and need to lift the voices of the Ohio Black Maternal Health Caucus as well. They have been very clear in their position statement in support of perinatal support workers and doulas. We invite you to go to their website to see the entire statement. And you can also see the entire statement on our website at www.ROOTT. We recognize that there are some hospitals that are allowing up to 2 people in the delivery room, which can be spouse, family member, and the doula. To those hospitals, we say thank you for continuing that policy. For hospitals that continue to restrict doulas and perinatal support workers, we urge the following: that a support system in all rules, such as being asymptomatic for COVID-19, and all screening protocols of healthcare institutions, and the allowance of a perinatal support worker or doula in the delivery room when requested in their professional capacity. Next slide. Next slide. Because with that, what we know that we can do, and this is one of our favorite photos, if anyone has seen any of our presentations before, we see this frequently and it is up on our website. This is who we are. We know that we can experience Black joy. We know that we have experienced multiple trials and tribulations throughout our history in this country, and we know that we have come through those with resilience and have been able to thrive in multiple ways. And we will do so again, even through COVID and a pandemic. We know that we will be able to come out on the other end of this. So very specifically to the healthcare providers that are on this call today, on this webinar, and to the families that may be listening, and to those that are pregnant or considering having their own family, Know that we will come through this. Do not be afraid, because we know that we have the skills and the abilities to be able to care for ourselves within our communities. We want to take this opportunity to make sure that we again thank the Ohio Black Maternal Health Caucus for their position statement. I want to take an opportunity to again thank Black Mamas Matter Alliance and all of our kindred partners and collaborators. It is a continued joy to be able to work with everyone and to have the resources that we do in collaboration. Also want to, most importantly, thank all of our staff and administration at Root. They have really come through this time of incredible levels of stress with grace and professionalism and care, that we have been able to hear that again from our communities as well, feeling like they are supported through this time. And we could not do this work if it wasn't for our folks that are on the ground, both virtually and still providing the in-person support where allowed. And that's all that we have for today. Thank you so much for giving us the time to speak about the doula policies during COVID.
Thank you so very much, Jessica. This is highly appreciated. And thank you for sharing this wonderful information and all the work that you and Root is doing, especially in Ohio. Thank you also to all of our presenters, including our guest speaker, Congresswoman Lauren Underwood. Thank you everyone for lending your time and expertise on today's webinar. We hope you have learned something new and that you will be able to apply some key points from today's webinar into your daily work. All presenters will remain on the webinar until close to answer any questions sent through the chat box. But before we go to the question and answer portion, I'd like to highlight the following announcements. Be sure to join us for the rest of our webinar series this week. One tomorrow entitled Improving Health Outcomes for Black Mamas Through Holistic Midwifery Care. We are going to have some dynamic and spectacular midwives from across the country to be on that webinar. Also, the last webinar during our webinar series for Black Maternal Health Week will happen on Thursday, Centering Black Mamas in Practice. We will also have some spectacular presenters who are going to talk about the work that they do in their communities as well across the country. All of these webinars will start at 2 p.m. Eastern Standard Time. And again, registration for these webinars can be found at blackmamasmatter.org/BMHW. Please note that all webinar recordings will be available on our website soon. Additionally, attendance certificates and continuing education credits for these webinar series for now are not offered at this time. I'll now turn it over to Rose Arca-James, our National Membership Manager, who will be fielding questions from the chat box to our presenters. Rose?
Thank you, Angela, and thank you to all of our panelists today for such incredible presentations. I'd just like to reiterate what Angela said. All of these webinars for this week will be available on our website after Black Maternal Health Week. We do ask that if you are going to use these slides or these webinars in your classes as presentations, you make sure you always cite the presenters themselves. It's so important to cite Black women. We take that very seriously as an organization. So I just want to reiterate that point for folks who are interested in perhaps using this material for other uses as well. So today we're going to take about a few questions. We'll take 5 questions tops that folks have written in the Q&A box and also in the chat box. The first question is, I think it's directed towards you, Jack, actually. It says, is there any legislation that is currently underway to address the uniform collection of maternal mortality data at every hospital across America so that we can really disaggregate the data, see the disparities that African American women are experiencing? I'm sorry, Jack, I think this is a Dr. Parrott question.
Oh, sure thing. Go ahead, Dr. Parrott.
I'm sorry, Rose, could you say that again? Could you repeat the question for me?
Yes. Is there any legislation that is currently underway to address the uniform collection of maternal mortality data at every hospital across America so that we can really disaggregate the data to see the disparities that African American women are experiencing?
And Jack actually may be able to answer that better than I. But because I'm not aware of any that is being put forward at this point. That doesn't mean that there aren't folks that are working on it. But the challenge there is sort of where the standardization and how enforceable it is at a hospital level, given the sheer number of hospitals and birthing places around the country. So I'm not aware of anything on a federal level that does that, but certainly there are efforts at state levels to try to encourage through the Vital Statistics Registry to be able to standardize the data collection, and it's happening at a state level, but I'm not aware of anything at a federal level to do so.
Yeah, thanks, Dr. Parrott. And just to add on to that, I think everything Dr. Parrott said is spot on. And one of the bills that we referenced in the Momnibus, the Data to Save Moms Act, includes a task force. One of the goals of the task force is to begin the process of standardizing data collection. As Dr. Parrott mentioned, it really is fragmented across the states right now, but as the question acknowledged, because of that fragmentation, it does prevent us from drawing some really important trends and conclusions. And so one of the goals of the Data to Save Moms Act is to get us in the direction of standardization so that we can have evidence-based, data-driven solutions.
And this is Dr. Parrott again, and I would just add that the question of standardization is a complicated one because it takes us back to this question of what we're going to count and how we're going to count it, and really eliminating the ability for these counts to be open to interpretation at the individual or at state or community level. The other thing, and that I think it's important to recognize, is there's a good deal of financial resources that are required to not just standardize the data, but to actually collect it in real time as these cases move forward. And so we're so grateful for the legislation that is really emphasizing the importance of doing so. And so much of that needs to be tied to funding so it can actually happen as well.
Thank you, Dr. Parrott, and thank you, Jack. A participant asks, I'm interested in knowing more about how the Momnibus bill will work to address the disparities we're already seeing in the COVID-19 crisis as far as Black folks experiencing a much higher mortality rate than white folks and other people of color. Will parts of this bill work to address this mortality rate disparity as well?
Yes, that's a great question. And I'll say, the process of developing the Momnibus, really began last summer, long before this pandemic was on anyone's radar. So although the Momnibus wasn't designed specifically to address COVID-19, I think there are definitely aspects of it that would address some of the challenges, as the Congresswoman said, that are being revealed, if not exacerbated, by this pandemic. And I think Jessica's presentation, that extraordinary web that she showed of social determinants of health, when you think about the Social Determinants for Moms Act in the Momnibus, I think that's an example of legislation that, although it wasn't initially drafted with the pandemic in mind, it certainly would have implications for some of these really grave disparities that we're starting to see in COVID-19 outcomes as well. And we're certainly thinking really with great concentration right now on what types of legislation can be advanced to address these disparities, and look forward to hearing from communities across the country and Black women who are experiencing this on the ground of what some of those policies might look like.
Thank you, Jack. We have a question. Attendee asks, with CDC guidance, many MMRCs are estimating preventable pregnancy-related deaths in their jurisdictions and creating recommendations to avert them. Can you speak to the framing and challenges of estimating preventable pregnancy-related deaths?
Sure, I'll take that. This is Dr. Parrott.
Go ahead, Dr. Parrott.
I'm sorry, I was talking way on mute, of course. I wanted to start out by acknowledging that certainly every pregnancy related death every maternal death is a tragic one. But when we're talking about the preventable deaths, the CDC estimates that about 60% of maternal deaths are preventable. And what they mean by that is that if there's a reasonable change that can be implemented that might have made this death avoidable. And so what that does is sort of, it takes a look at, it's grounded in sort of this idea, if we take a look at the most common causes of death during pregnancy, during labor and delivery, and the postpartum period, and figure out whether or not there are ways that those deaths could have been avoided, and that's what goes into those calculations. And so we see this play out a little bit in the AIM bundles, the advancing the maternal health bundles that are being implemented at hospitals, for example, some hospitals around the country, where it creates this algorithm for the most common complications that happen during the labor process. So high blood pressure, bleeding, and blood clots are leading the causes of death, and really says if we standardize the way we manage some of these outcomes, these incidents that happen during the labor and delivery process, would these deaths be avoidable? As the question presents, and this is a difficult thing to estimate, and it creates a challenge for MMRCs to make that estimate. And it also doesn't take into account all of the things that Jessica talked about that also impact maternal health, and things that we believe are avoidable as well. So addressing things like implicit bias that is embedded in our healthcare system, talking about the root causes of these structural determinants of health, reinvesting in our communities are also things that I believe are avoidable and contribute to the death of women. And those are things that are routinely counted as preventable, but I think that they're things that are critically important for us to evaluate as well.
Thank you, Dr. Parrott. This question has been addressed directly to Jack. It says, how is the Social Determinants for Moms Act and other policies, if applicable, addressing the underlying causes of social determinants of health, such as institutional racism and implicit bias? Black women are dying at alarming rates due to such underlying causes.
Yeah, that's a great question. And again, as Jessica's presentation showed, obviously all these social determinants are influencing outcomes, but as she pointed on that following slide, the underlying factors beneath all of those social determinants go far beyond just transportation or just housing or just nutrition. And these are tough issues to legislate. The social determinants bill does focus on those specific transportation, housing, nutrition. On your point about implicit bias and really trying to get to racism, in the Kira-Johnson Act, one thing I mentioned was these trainings that we're putting in place. And then, on the other side, the accountability mechanisms. But often we talk about these trainings in the context of implicit bias, and certainly important. But if you look at the text of legislation, we go beyond that, and we work closely with our stakeholders to ensure, and I want to shout out Dr. Joya Creer-Perry for all her guidance on this in particular, making sure that we're really talking about racism in these trainings, and taking that square on, and recognizing that trainings alone, again, are not going to root out racism, but these are a step that, when structured properly and again, being developed by Black women and following practices that Black women have developed in these trainings, it can be a step. But I think it's a really important question. And Jessica, I appreciate in your presentation the way that you addressed those underlying factors even beneath the social determinants.
Thank you so much, Jack. Our last question, an attendee asks, how can we as healthcare professionals and advocates get the moms/patients involved in pressing hospitals and medical centers to allow doulas as support persons?
I think that this is Jessica, I think that I'm able to answer that question. I think that, I know that first of all, getting the patients involved is necessary. That's always about making sure that the direct language and wording that's coming from the patients goes directly to the administration that actually makes a decision, meaning that often it gets intercepted by a pass-through through patient satisfaction, customer service type of situation, and then ultimately it's 2 or 3 months later before anyone has actually contacted. But I want to be really clear about this, because from being a nurse, a former clinical nurse myself, and knowing how the structure in the system works, it really has more to do with us as healthcare professionals being very clear about advocating for the voices of our patients and clients, and being very specific and pushing back on administrative policies and saying, this is not just anecdotal. This is happening too often. We're hearing this too many times from too many of our clients that are saying that they want to have this support person with them. We need to be addressing this and make sure that we're meeting the needs of our families. That's one. Secondly, we also need to point out, which we didn't discuss during the discussion, but be really clear that some of what has happened with COVID is that it has made it even more challenging for healthcare professionals to be able to continue to have regular visits with their patients. And you find that, in particular, at least within our organization, I know that's happening in other places as well, we're filling that gap. So when our folks aren't able to have the telehealth medicine visit, or aren't able to go into the office, or have a concern about going into the office because now it's a no visitor policy, that's falling on, again, the perinatal support worker or perinatal support doula to be able to provide and fill that gap. And so as healthcare professionals, we should be saying these mechanisms need to be in place, primarily because this is what the voice needs of our clients and our patients are, but also because it's a supportive internal mechanism for us as healthcare professionals to be able to make sure that we can continue to deliver quality care to our clients and to our patients during a pandemic.
Thank you so much, Jessica, and thank you to all of our presenters for answering all of these questions. That's it for our Q&A session for today. Again, as a reminder, all webinars for this week are being recorded, so you will be able to view these on our website after Black Maternal Health Week. Again, we ask you that if you are going to use any of the webinars and use any content from presentations presented by our presenters, make sure that you're citing their work directly. Thank you so much, and I'm going to turn it back over to Angela.
Thank you so much, Rose, and thank you again to our presenters, and thank you so much to everyone who has joined us for today's webinar. We hope you gained a new understanding of shifting and advancing Black maternal health policy by attending this webinar, and will use this knowledge in your daily work to become champions of Black maternal health rights and justice. You can continue to engage with us throughout the Black Maternal Health Week campaign by following us on all of our social media platforms and through the hashtag BMHW20. Visit our website for additional information about the Black Mamas Matter Alliance. Sign up for our newsletter to also be involved in any one of our future initiatives. With sincere gratitude for your attendance for today's webinar, we thank you. Have a good one.